It's very great to be back in Netherlands. I've been here 7 years ago to enjoy the hospitality of its great people, this great country. My story will be a bit different than what Jan said. Yes, because I graduated, I did my general surgery. I graduated in 1991. And then I worked for about 3 years as a general surgeon and then joined a hospital where I was fortunate to have plastic surgeons from Norway and Sweden. And they have worked really for a long time in Ethiopia. And I was really hooked. When I just joined them, working with them, I was hooked in the profession. And after working with them for 2 to 3 years, they found for me, funding and a place where to study to do my plastic surgery, India and Norway. And I'm very proud and really happy to tell you that my 2 years training in India was supported by the Netherlands Embassy in Ethiopia, and really I owe to you in this aspect. So that I am at this level and talking to you on this subject. I work for the Flying Doctors of Africa, and I have been working for 12 years now. And I have operated mainly children in 14 countries of Africa, and I've done thousands of surgeries in these countries. And I have also, I did participate, contributed in training so many surgeons in Africa, which I'm really very proud of. But before I start my presentation, I would like to recognize the presence of Dr. Tom Rassen here, a Dutch by nationality, an African by, what to say. So he's more African than Dutch, and he has worked for my organization for more than 28 years, and maybe in between I'll mention a few things when I go on discussing. So greetings from the Flying Doctors of Africa, and we are based in Kenya. This is the headquarters. This is our headquarters in Nairobi, and this is the office which we are sitting in Nairobi. There will be some repetitions unavoidable, but I would focus mainly on issues which would be of interest for the young doctors here. So, as I mentioned to you that how you should prepare yourself to go there, what I will maybe discuss is what do you see when you come there? I think that will be the kind of my 15 minutes to discuss with you. So I will not, I try as much as possible not to repeat what the others have said. Most of our activities are in Eastern Africa, but that is more or less the same for sub-Saharan Africa. And you see how the situation in all parameters is desperate. This has been said. And there are only about 30 reconstructive surgeons for a population of 200 million, and that area is equal to Western Europe. So it's like almost one reconstructive surgeon for 1 billion people. And you see, for 100,000 population, we have to multiply our number of doctors by 10 to reach what your level is today. So it's very desperate. And you can see here that in ideal circumstances in Europe, 15.2% of the women there's the chance for cesareans to deliver surgery, whereas in Africa is only 3.6%. So more than 80% of those who needed this surgery do not get the chance of. And what does it mean? Some of them die, and some of them get complications like birth injuries and the like. This has been already mentioned, more or less is a repetition. Just to share with you one story, what I found a patient in South Sudan about 1 year ago. This lady is 65. She had this for 15 years. Imagine how disabling this is. And guess what it is? It is a pedunculated lipoma. 20 minutes surgery, here she is. Actually, what I was saying to the colleagues who were there is that the woman herself could have cut it, this one. You know, it's so pedunculated and the like. But for 15 years, she has been living with this. Really, this is unfortunate scenario, which... so, for the young fellows, just this summarizes the whole thing which I am going to discuss with you. What do you see there than what you see here in your practice of reconstructive surgery? Of course, there is a huge gap between demand and supply. And most of the trainings of our surgeons is in abroad. And it is practiced in a demanding environment. The facilities for surgery are poor. And the disorders encountered seen at an advanced stage. And some disorders we see there, you might not see them at all here. So actually, this is the layout of my presentation in simple terms so that I meet you there. So there are a lot of children or adults with unmet surgical needs. This has been already discussed. And we are talking about 100,000 cleft lip and palate patients awaiting surgery. It doesn't mean that we are not doing anything. I would like to share with you a few stories what we have done in the cleft field. 2006-07, the Flying Doctors started the scaling up program of the cleft services. And to date, we have done more than 7,000 cleft operations, and we have internet-based data for each and every patient we operated. And not only this, only in Eastern Africa, we trained surgeons, general surgeons, in doing cleft surgery, and we have done 7,000. But through this exercise, we have again another database of all what is done by those surgeons we trained, and they have done 33,000. So you can imagine, in 6, 7 years, 8 years, we are able to do more than 40,000. This is a possibility. And doing nothing is not an option. So we do this also with collaboration of surgeons from many countries. Again, I want to share with you, of course, injury is a very common problem. This has been already said. Many hospitals we go visit, there are unattended open fractures which are crying for cover and asking for plastic surgeons to come and do something. About burns, you have already said. And most of disorders encountered come at a late stage. You won't see in Netherlands similar things there, but same story like the old man Jan has been mentioning, this patient of 65 years. I was in Ethiopia at a mission where there were more than 100 cleft patients turned up, and this man was among them. And I categorically told him that I cannot operate him and will give priority for the children. And we started on Monday. He came on Monday, then Tuesday, and then Wednesday he challenged me. He really requested again that I give him the chance of surgery. And then I said, I tried to explain to him what it is. It's too late for him and this. But he challenged me again and said, I was lucky. I was married and had children and grandchildren. He said that I'm not educated. He's just an ordinary peasant. If I was educated, he said, I would have written a big book of what suffering I've gone through all in life. He said that now he's very much affected with this thing than any time before because his grandchildren are running away from him, and really he was desperate for this repair. Then I changed my mind. I decided to do him. And he went up. He's just under local anesthesia, 30-minute surgery. 6 months down the line, I went to that place. He came again. I saw him happy, and I asked him, how did you come? How is life? He said that he's so happy living, like the same day he was operated, it's like he's reborn that day for him. And he said that he's enjoying life with his grandchildren. And I asked him, why did he come? Because he came from a long distance. He told me that he brought from his village 5 children with clefts. And he asked me that to make sure that they are operated so that they don't go through the same experience you have gone in life. This is the kind of thing which are encouraging us to do more and more. So people come on advanced stage, and some pathologies you don't see. You don't see here. You see them. These are very familiar conditions for Dr. Yan and this team, the Dutch NOMA group, NOMAs. Keloids, albinos with skin complications because of lack of melanin, leprosy, hand paralysis, polios, all these are waiting for surgery to improve their quality of life in one way or another. Challenge, resources, lack of resources. This has been mentioned, so I don't want to report. But when you start reusing the gloves, this is a very dangerous sign. When you do lock your shoes in the theater, this is not a good sign. But this is the reality in Africa. And again, also, you don't have, all the facilities you need. So you have to use even technologies which have been used before in Europe, or you could still do operations which are not very much commonly done, like Ruckenberg operations or polycization for that matter. This is also very important. You have to, if you don't have the facilities, you have to settle for less. When you cannot do total term transfer or something, then you go for less, and then you do polycization. And so it's a demanding environment, but you can do something out of it. The anesthesia complication, anesthesia risk, we have been discussed. You see this picture, I like it really. It's the patient anesthetizing himself in a gas. Well, the anesthetist is there. This is a common scenario. I'm almost done. Now, training is the only solution, really, to improve the scenario. The bottleneck is lack of trained personnel. So I tell you, I am a personal witness for the benefit of having European or American doctors in Africa, because I have gone through the formal training, but most of my skills and knowledge I have learned from visitors. We get visitors from all over the world. I pick one from one, and all gathered, it has made me the person I am now today. So this interaction is very important. And then again, also, a training program in Addis. You know Yekati 12 Hospital. My sponsors from Norway and Sweden, and when I came back from my training in India and Norway, we jointly initiated this training program to the support of Norwegian government. And I was the last person to be trained outside the country. Since then, after this program, 12 reconstructive surgeons have been trained to this program to date for the last 7 years. So out of the 30 reconstructive surgeons, I'm telling you, in the area of 200,000 people, 12 are trained through this program, and the program is functioning very well, and now we are even working that trainees from other Eastern African countries go and learn reconstructive surgery in Yekati 12 Hospital. So this is a model, and we can do it. It could be done, but the proper structuring is very important. One has to do really needs assessment, and then initially it should be really institution to institution collaborations, and it does work. You know, I'm not very much convinced when some of our presenters mentioned, not these sessions, but previous sessions, that the government or the politicians are not interested. I don't think that's the case, because Africa has a lot of challenge. You know, you have to see on that context, but the will is there, the desire is there, but we need to be really very patient so that we make a difference in the life of so many people in there. Come on. Okay, yeah. So the way forward. The best gift you can give to individual is really knowledge. So I really encourage you very much to interact with our fellows. And that also will give us to a solidarity, you know, friendship, the network. Right now, as we speak, we have a Dutch team of ENT surgeons who are in Kenyatta National Hospital, and they have been going there, and they will go to stay for 3 weeks, and they have been going then, as far as I know, for more than 7 years. And the impact they have made is great. Really, we really are looking forward to such collaborations, and this is the way forward. There should be a mechanism where we have to decrease the gap of the health service, reconstructive surgery service available in Africa and Europe, and the only means is through working together. Of course, not all is perfect, but there are challenges, but challenge should not be obstacles. So with this, I thank you for your kind attention.
Thank you very much for your lovely presentation. Ladies and gentlemen, it's now time for questions. Has anybody got a question? Simple question, difficult question? Cannot be that nobody has a question. Right, thank you. The best is that you stand up because you don't have a mic, then we can hear you.
I have a question for my readers. Thank you for your talk. I was wondering, did you see improvement on all your short stays, and what improvements at the hospital? What did you visited? Did you see?
Yeah. I think that's a very good question. The thing is that there are differences in the amount of effect you see from your stay, and that obviously comes from two sides, from the giving side and from the accepting side. And I think that we may have had lesser results because we didn't have the right approach at that time, and also sometimes we had not such good results because of local factors, like when the pressure with the workload for the local doctors is extremely high, then they just simply do not have the chance to be with you in theater, because there's other things that they have to take care of, because there's trauma patients, there's acute cases, etc. So it's not always possible to get the optimal result from your stay. That's why I said, and like Dr. Mengiste said as well, there's much to gain from coming back to the same spot for several years in a row, because then, first of all, you get to know each other better. Then they know how you want to work, what to expect of you, and what they can learn from you. And they will, by themselves, because everybody wants to learn, wants to improve. So by themselves, they will start to organize also ahead, like I told you we should do, but you can't tell them you have to arrange this ahead because they say, oh yeah, well, you know, this is so many teams I have been here. Let's wait and see what how they want to work and what they can do for us. But after the first trip, if that is a mutual success, then it starts working. And it also depends on the setup, because we have been on several missions where teaching was actually the mainstay of our mission, which is different from when you go and you know there's 120 patients waiting for you and you have to sort of deal with them and try to have them operated before you leave. So there's several, like everything, there's several ways of doing it and several things that influence it. But I think if you have the intention to combine the teaching with the individual patient care and have the intention to go back to the same hospital for several years in a row, then you will see that you have success. Like we have trained doctors in Africa who are, and there was one hospital we didn't have to go back anymore, because they could do split skin grafting, they could do simple transpositions, so they could take care of their own burns contractures, they could do their own clefts, and also for the rest of the thing, you know, you see the whole level of expertise in the hospital go up. And then at a certain point we said, well, there's so little left for us to go there, why don't you do it yourself? And that's fantastic. You know, it makes you sad because you have become friends and you want to go back there. But it's fantastic. It's the way you should not need to do this. Well, lucky enough, there's several years to go before that is settled in all Africa.
Thank you. More questions, please. Seems there. Oh, thank you.
Just a comment, really, more than a question. I just want to thank Dr. Jan for his honesty, because I go to an awful lot of these global surgery conferences, and I present at a lot of conferences myself. And I know we all generally stand up there and talk about how everything we've done is fantastic and how everything has worked perfectly. And for none of us is really, you know, entirely positive. Obviously, there's good things and there's bad things. I think we learn more when we talk about what didn't go well. So I just want to really applaud his honesty, and I'm going to try to follow your lead and try to discuss the things that didn't go so well and maybe why they didn't, because I think we can all learn more from that.
Thank you very much for your comment. More questions, please.
I have one question.
Go on.
I was wondering, Dr. Mengiste, because you're from AMREF, flying doctors, you're not fear of flying? Because all the time you hear these small planes going down in hailstorms and what have you.
Thank you, Jan. This is our brand. I have been with the Flying Doctors for 12 years. I will give this floor to Dr. Tom Rassen, who have done it for 28 years, but I will answer it myself. You know, the aircrafts were the tool of the time, like 50 years ago when the Flying Doctors started. And otherwise, there was no way you could reach there. And now there are also, out of the hospitals we visit, we work with 150 hospitals, like 20% of them are not accessible either by road or by commercial flight. So we have our own planes, so we use our aircrafts to go to those places. But the remaining 80% of the hospitals we use as a commercial flight or by road. And so the chance of me flying would be like 1 week in a month. And our aircraft, the caravans which we use, by the way, one of the caravans were donated by the Netherlands people. So they are so safe. 12 years, I haven't encountered a single incident of anything. So there's no reason for worry.